Good morning, students. I'm going to be going through Chapter 7 today. We will be doing Chapter 6 in class, and this is just, I'm going to be covering a little bit more about pain management during labor and birth. So when we're talking about childbirth education, ideally a woman starts to prepare for this even before she becomes pregnant, but I think the reality is most of the time this preparation starts happening after the pregnancy test is positive. We would like a woman to be taking care of herself as if she was pregnant, even before she becomes pregnant. So taking her vitamins, making sure she's getting enough folic acid, not smoking, drinking, doing street drugs, that sort of thing. So some of the classes that are available out there, here's some options for some of those classes. A lot of these are not available locally. We do have Baby Basics, which is infant care and breastfeeding available at our hospital. And I think most of the hospitals offer something like that. There used to be all of these different options, but there just doesn't seem to be anymore when you're only getting 2 or 3 people a month coming to these classes. They're not feasible to keep going. So this is really wide open for someone to maybe get some grant money and provide some of these classes, especially in different languages. This is certainly something that you as a nurse could do. We used to also offer lots of different ideas, refreshers, cesarean birth, vaginal birth after cesarean, and adolescent. Again, none of these are available now. We mostly focus on childbirth education. So some of the things that can be covered are listed here as far as what's in a childbirth education class. For mine, we spend some time talking about coping with labor and delivery. We talk a little bit about nutrition, some common discomforts, and signs and symptoms to report. And then we spend a lot of time talking about the actual process of birth. So if you understand what's going on, then hopefully you have a little bit easier time dealing with it. There are some great resources here, babycenter.com, pennysimkin.com, lamaze.org, and evidencebasedbirth.org. These are places that I send my students that are in my childbirth education courses to. I like this information for moms. Lamaze.org offers an entire childbirth education course that you could just take online, and highly recommended. So childbirth and pain, how is it different? How is childbirth pain different than any other pain you might experience? Well, one of the things is childbirth pain is normal pain. It's not like cut off your leg pain. This is the kind of thing that you have a contraction, it lasts for about 60 seconds, it builds up, it peaks, and then it comes back down, and then for 3 to 5 minutes you have no pain. And then it does that again, and then for 3 to 5 minutes you have no pain. So it's a normal part of this labor process, and it is not like cut off your leg pain that would be constant. So women have lots of months to prepare for this type of childbirth pain, and this is what some of what childbirth education courses would actually help them to do. It is self-limiting. It goes away once the baby's born. There's still some cramping after delivery, especially as you have more than one child, but it's not the same as labor pain. So different things influence what is going to cause pain in labor. Some of those are the patient's own pain thresholds. Every woman has a different threshold for what she can handle. And sometimes it's going to be different in each labor because of different circumstances. So for instance, the size of the baby, the position of the baby, how exhausted she is, all of these are going to influence how she feels about the pain in labor. How ready her cervix is, what shape pelvis she has, the position and presentation of the baby are all going to make a difference. So one of the things we like to tell women is that the more relaxed you are, the easier it is going to be to deal with actual labor pain. So I would let women know that these non-pharmacological pain methods are going to help, even those that plan on getting an epidural at some point, because the more relaxed you are, the less you're going to hurt, and maybe you can delay that epidural for just a little while. We also have our own natural endorphins. Anytime we are experiencing pain, our body produces some natural endorphins, and that helps us deal with that pain. But when we start influencing that with our pharmacological pain methods, our body stops making those endorphins. And so it can actually be way worse at the end of labor if we don't have our own natural endorphins present. So some of the things that about non-pharmacological methods is that they don't slow labor in any way. In fact, they can speed it up. They don't cause any harm to the mother or the fetus. They carry no risk for allergy or adverse drug effects. There's no reason we shouldn't be doing them. There's absolutely no reason not to use non-pharmacological methods. But what happens is our labor and delivery nurses and our moms have not been given these tools. And so that's part of my mission, is to make sure that they get these tools. There's lots of different theories of how you can utilize these non-pharmacological methods. These are theories for labor, and I'm not going to ask you to know any of them, but if you're interested, you can look at the Lamaze theory, go to lamaze.com. There's the Dick Reed method, and then the Bradley method. So some of these non-pharmacological pain relief measures would be skin stimulation, massage, that nice soft touch like effleurage, using counter pressure, sacral pressure, putting pressure up against the back, especially if she's having back pain, either heat or cold, using ice packs or heat packs to help with the pain of labor, repositioning that mom, helping her get into upright positions, things that are going to help, diversion and distraction, using imagery, using music, using rhythm, sound, counting, and then our breathing techniques. We have lots of different breathing techniques that we can use. I just like the nice slow in through the nose, out through the mouth, and that kind of breathing helps everybody. And so these are things that we can help our moms with. This is a map of labor support and different techniques that can be used. And you can see there's the epidural highway and the detour for back pain. And this is just showing that there's lots of ways that we can support this mom during her labor, and that laying in bed strapped to a fetal monitor is not the only thing that we can do for our moms. This is a tool that we use to see how well our mom is coping. We're able to look at the signs and symptoms here of, is she coping? And then the signs and symptoms if she's not coping. And then we can come down to the next level and we can see the different things that we can do to help. If she's coping well, we might just offer some emotional or psychosocial support. If she's not coping well, maybe she needs more of this. We can control the physical environment. We can control we can start using our pharmacological methods to help. And then we're going to reassess and see how well she's coping. So spend a minute looking at this, and you can see these are the types of things that we are doing as a labor nurse to decide if that mom is coping well. This is an example of some positions that you can use with a birth ball. It's also called an exercise ball. Mom needs to bring this with her to the hospital if she wants to utilize it. We highly recommend them. Here are some positions that we can get the mom into with an epidural while she's laboring, because we need to be moving her every 15 to 20 minutes to mimic what she would naturally have been doing herself. And here's some positions had she not had the epidural. And then here's some positions that we can use with pushing while with an epidural. This is a brochure about our peanut balls. We have these peanut balls actually in the hospital, and these are fantastic for mom to utilize when she is either laboring out of the bed or laboring in the bed. There's lots of different positions. They've kind of gone to this peanut ball shape because it's a little bit safer than the birth ball. That's why we provide these in the hospital. And we have different sizes, and that we have to measure to make sure that we're using the right size for the right patient. This is a good tool. Here's the different kinds of breathing techniques, and I'm going to show you some pictures here of what these actually look like. There's some good videos on your YouTube video list this week about using breathing techniques. Here is a person that is not using her breathing techniques very well. Looks like she's doing more screaming than breathing. But here's some different patterns, and you can spend a minute trying to do these patterns. So this big deep is a and the small is a. So you're just using this to know what kind of pattern of breathing to utilize. If a patient is hyperventilating, we need to recognize that right away. She might tell you that she's feeling dizzy. She's having some tingling of her hands and feet. Maybe she's having some muscle spasms or cramps, maybe numbness around the mouth or nose. If she's having blurry vision, she's on her way to passing out. So we need to use some corrective measures. And one of those things is to show her, take a deep breath Count to 3, 1, 2, 3, let it out. Or she might take her hands, cup them around her nose and mouth, and then breathe deeply. We need to get her out of this hyperventilation. If we don't, she's going to pass out. And when she passes out, her oxygen level is going to go down and her baby's heart rate's going to go down. And so we need to keep her from hyperventilating. Here's a woman that's breathing deeply and managing her labor, managing her contractions, and doing well. Here's a picture of someone that's not coping as well. So this is our job, to assess how well these women are coping. One of the rules is, if a woman is coping well, we do not interfere. If you stop this video and go to this YouTube, you'll see this woman is 8 centimeters dilated, and she is dancing her way through labor. She is coping well, and we certainly are not going to interfere. It's a fun little video. So one of the things that we can do is determine if they've attended childbirth ed, how prepared they are, how important this is for them. If they tell you on a scale of 1 to 10, it's very important that they do not use pharmacological pain techniques, then we are going to help them. But if they say, well, you know, I'm going to try it, but it's only about a 2 on the importance scale, then we know that when she starts asking for something for pain, that we're not going to spend much time doing this sort of thing, because that was already in her plan. So we're going to look at signs of tension. This woman has a very relaxed face. She's doing very well. This doula is providing some support. Possibly that's a nurse. She's hanging on to her partner here. So we're assessing how well she's managing it. And we're also minimizing her environmental irritants, keeping her clean and dry, keeping the lights down low, turning off the TV from that incessant chatter that is on when you've got a TV program going on, helping her focus on her job at the moment. So now we're going to talk about pharmacological pain techniques and the things that we have. We can give her usually IV narcotics. Fentanyl is the one that is used most, occasionally Stadol, but usually fentanyl. Sometimes we can give her other drugs that go along with those to make them a little bit stronger. I don't see that used very often anymore. But sometimes we also have to give her some pain medicine to counteract the nausea vomiting that's caused by the pain medicine. I mean, some medicine to counteract the nausea and vomiting that's caused by the pain medicine. We can use regional anesthetics, which is going to numb the woman. That's our epidural, or a spinal, typically used for a C-section. And then we have general anesthetics, and then those are typically used for people that cannot have spinals during a C-section, or in emergency purposes, if it's an emergency delivery. So a woman is at higher risk after she becomes pregnant for hypoxia. And when we're giving her pain medicine and she's not breathing as well as she was before the pain medicine, because it causes respiratory depression in both the mother and the baby, she can be at higher chance for hypoxia. So we need to be putting an O2 sat monitor on and watching that mom. The other thing that when we give narcotic medication is it slows down the GI tract, and she already has a slower GI tract because she's pregnant and having all that pressure pushed up against her bowels. So we need to think about this when we're giving any sort of narcotic medication. We need to let her know that she's going to need to be taking some Colace afterwards, because we don't want her to be constipated after she delivers. When we are using pain medicine, we want to make sure she's not laying flat on her back. We talked about this before. A pregnant woman should never lay flat on her back for a period of time, because it causes that compression of the vena cava, and that decreases the blood supply to both her and the baby. And then lastly, we need to really be considering what's happening to our baby when we're giving this pain medicine. When we can give up to 6 doses of your fentanyl, and we can give it every hour. But if on the second hour we notice that the baby's not tolerating the fentanyl, we can't give her another dose until our second patient, the baby, is tolerating it. So these are conversations that we need to have with the mother before we start down this pain medicine highway. So using medications during labor allows the mom to be more comfortable and relaxed. This is a woman that's just recently got an epidural. We really need to encourage her that this is her time to rest and get rested up in order for her to be able to push her baby out. This does lessen the stress response when she's feeling better and not feeling those contractions. We need to let her know that at some point she will start feeling something again. It's never as good as when they first do that epidural, and that's on purpose, because we want her to be able to feel so that she can push her baby out. So we need to remember the fetus as well when we're giving these medications. And if we give these medications too early, it can actually slow labor down. So now we're going to have to give her medicine to speed labor back up. So we got to think of this cascade of events that's happening with our, potentially with our pharmacological methods. Here's a picture of a fetal heart strip. And you can see this baby has good variability. You've got ACT cells. It's within normal range. This is a baby that's doing very well. This is a picture of a baby that the mom just had fentanyl. So you can see that this baby slows its heart rate down in response to that fentanyl, and no more ACT cells. It gets very sleepy. Just like mom, we have now medicated our baby. So we have to be on the lookout if this baby's not tolerating this. We try to avoid giving narcotic analgesia within an hour of delivery because it causes respiratory depression in the baby. And we have to be prepared to support that baby's respiratory function if it's not doing well. If it comes out and it's not breathing, we're going to have to breathe for it until it is going to breathe. And like I mentioned before, sometimes we have to give medication to control the nausea and vomiting. This is epidural anesthesia, and I like to show you pictures because your patients are going to ask you questions, especially when they say things like, oh, I don't want that shot in my spine. You're not actually getting a shot in your spine. They use this long needle to go through, these are your vertebrae, and to get into this space that is just outside the spinal column where the spinal cord lives. So you've got this thick covering, the dura, and this is where your spinal fluid is bathing that spinal cord. And we go just outside that space. They enter a little tiny thin catheter. I have pictures of it. And then they take the needle out, and then the catheter stays behind and drips medication into that space. And I'll show you more. This is what it actually looks like. This is the nurse's role to get this woman in a good position so that she can drop her shoulders and relax her back so that they can get through the vertebrae and into that space easily. She's still having contractions while this is happening. It's the nurse's job to make sure that she's staying nice and calm and in good position. Everyone will be wearing a mask at our facility because it's a sterile procedure, and the father or partner are expected to sit down. They cannot be the support person. We don't want them passing out and being injured. So this is the needle that's used just to guide this catheter in. Once the catheter is in place, this needle comes out and just the catheter is left behind. Nurses take the catheter out once the patient has delivered. Anesthesiologists do this procedure. So the difference between analgesia, which is just taking the edge off, and anesthetic is numbing. So analgesia just kind of blocks the pain sensation a little bit. It really helps you to deal with the contractions a little bit easier because it's just helping you relax. So one of the things that happens in your pain response is you're breathing faster, your heart oxygen consumption is increased, you have a higher blood pressure, increased cardiac output because you're hurting, and your blood, I think I mentioned, your blood pressure is higher. So one of the things we want to do is try to decrease all of those things. And we can do it through non-pharmacological methods if they're working for the mother, if she's able to calm down and relax during that. But if not, we might have to use some of these other methods, because if all of these things are going on, then we are having some all of this is going to affect the baby and how well the baby is tolerating labor. So an anesthetic is actually going to numb the sensation. They're not going to feel it. Almost all women are completely numb with an epidural, but some do feel some pressure, and occasionally there are women that feel a lot in one little small area. We call that a window. So the other things that we can use is a local, and that would be placed down at the perineum, maybe for a repair of an episiotomy, or repair of a tear. They occasionally will use a pudendal block as well. Pudendal is a local anesthetic, but it's placed at the top of the vagina. So they use a long needle to give a shot way up top. I don't see these used as much anymore, but occasionally before forceps or vacuum, they'll do a pudendal. We already talked about an epidural. A spinal is, I'll go back just a minute, a spinal is used when we're going to be doing a C-section, and they use a much smaller needle, and it's placed inside the dura, and they just inject a little bit of medication. That's so it could be a heavier block, and they don't have to leave any sort of catheter there because they know if it's going to be for a C-section, it's for a definitive amount of time. With an epidural, we don't know how long it's going to be till she delivers. So with the C-section, they just give a spinal and just give it one dose, and that medicine lasts for a specific amount of time. I'm going to jump forward again. And then general anesthesia, again, that's used for, typically used in emergencies. So this is showing you that your epidural is really meant for these nerves in this area, and your spinal, a heavier block, usually numbs a woman all the way down to her toes. And you can see the picture above there that was showing the differences. This is just another picture of that thin little catheter that's left in that space that's giving the medication to the mother continuously. Now, occasionally with an epidural, they can actually cause a little nick in that dura, and some spinal fluid will come leaking out. What that means is the mother's probably going to have a spinal headache because it causes some pressure. The spinal fluid's leaking out, and so then the brain kind of presses down into the spinal cord, and then that's where we get a spinal headache. So one of the things we can do to counteract that is we can have the anesthesiologist will have you draw some of the mother's blood, and they will place it back in that epidural space. This mother's blood will clot off and stop that leak from letting any more fluid out. And this actually usually fixes it pretty quickly. So a general anesthesia, again, is only used typically in an emergency or if the woman is not eligible for a spinal block. We aren't going to have any family members in when she's had general because she will be intubated. So this is what it looks like as the woman is going to sleep. She's going to have a mask on that's going to give her some of the gases that put her to sleep. As soon as she falls asleep, the anesthesiologist will intubate her. And at that same time, they are quickly going and making an incision in the uterus. This is the uterus. Going down the layers, making an incision in the uterus, and pulling the baby out through that incision. They have to do it very quickly after general anesthetic because we don't want the baby to get the anesthesia. We want to hurry up and get the baby out before that anesthesia gets through the mother's bloodstream and to the baby, because we don't want the baby under general. Here's a picture of a baby being born by C-section, and then it will be dried off and taken over to the mom. We do worry about respiratory depression, and sometimes they have to do some resuscitation with those babies if they didn't hurry and get the baby out quickly enough. The other thing we worry about general anesthesia is once the mother goes to sleep, she has a much higher chance of throwing up and having an aspiration of some of the contents that are in her stomach. This is why women are not allowed to eat heavy meals in labor, because we worry that if they had to go to an emergency C-section and have general anesthesia, they're at a much higher risk for aspiration. Some of these rules have been changing in the last few years because they realize that very rarely do we have to use general anesthesia, and once we get that woman intubated, that risk of regurgitation is very minimal. So our pharmacological techniques, the role is it begins at admission. We want to know what her preference for pain is. We want to keep those side rails up once we've given narcotics, and we want to make sure she knows that she needs help getting up to the bathroom now because she might be a little dizzy. We're going to talk about the expected side effects and what the purpose of the medication is. We're going to observe for hypotension and respiratory depression in both the mother and the baby, and then we're going to document how well she handled the medication and reassess her pain. Okay, that's all for this lecture. I hope you enjoyed it. As always, you know how to reach me if you have more questions.